5 thematic priority areas, which we'll be focusing for the next 5 to 6 years. And you will see publications on these topics coming up over the next few years. These are health workforce, digital health, UHC and PHC, climate change and pandemic resilience, and inequities in health. These are the 5 areas. In addition, the APO produces health system reviews of the countries, the HITs, which are well known and well used by many people. Next. Thank you. So that's about APO. Now what I'm going to talk about is the main body of the conversation today. We are very lucky to have 3 of the main authors of one of our publications, as you can see in my background. This came out really a couple of months ago now, and it's on the website. And it was created because there was a felt demand that as the countries are becoming older, they need to learn from each other. As the aging population increases in a number of countries in the Asia Pacific region, we need to learn from best practice of what other countries are doing. And to do this, we worked with a number of institutions, and 3 of them are here to map how different countries, different cities are actually dealing with the integration of health and social care, as well as the public and private sector mix in their own setting. So to begin with, I would like to introduce Professor Hong-Soo Kim. She's from the Graduate School of Public Health at Seoul National University, and she's going to be presenting the situation in the case study from Seoul, Korea. Professor Kim is a renowned researcher in health and aging, and particularly in long-term care, workforce policies, and the role of technology in supporting aging populations. She is a Fulbright visiting scholar and a Takemi Fellow on international health. And she is also an expert member of the WHO Advisory Group for the UN Decade of Healthy Aging until 2030. The second speaker that we have is Associate Professor Alex Jingwei. He is the acting director of the Institute for Public Policy at Hong Kong University of Science and Technology. He's going to focus on the Hong Kong SAR case study. Now, Alex's work focuses on comparative health policy and governance with a strong emphasis on policy reforms and social protection mechanism in the Asia Pacific region. He's published extensively. He's been ranked by Stanford Uni as one of the world's top 2% most cited scholars in political science and public administration for 2022 and 2023. And finally, I'd like to welcome Professor Rama, formerly of the Center for Social Medicine and Community Health at Jawaharlal Nehru University in New Delhi, and an honorary fellow of the Institute of Chinese Studies in New Delhi. She's going to be presenting the Thiruvananthapuram case study in Kerala. Rama is a leading expert in health systems and equity with extensive amount of work on public-private partnership in health and their implications for access and quality of care. She's also a member of the Ethics Committee of the All India Institute of Medical Science, the Technical Appraisal Committee of the Health Technology Assessment at the Ministry of Health and Family Welfare in India, and the Scientific Advisory Group of the Indian Council of Medical Research. With that introduction, I would like to give the floor first to Hong-Soo. If you want to start, the order will be Hong-Soo, followed by Alex, followed by Rama, and then there'll be some questions, and then we'll open to Q&As from the participants. So I am going to click off, and I give the floor to Hong-Soo. Thank you very much, and welcome.
Good afternoon, everyone. I'm Hong-Soo Kim, a professor at Seoul National University's Graduate School of Public Health. It's a pleasure to share insight on Seoul's public-private collaboration model in elder care based on our study with the APO project. Today, I will highlight how public and private sectors work together in Seoul's healthcare and social care systems and discuss lessons that may be applicable to other aging society. Why Seoul? South Korea is one of the fastest aging countries globally. Over 20% of the population became to be 65 or older this year. Seoul, as a megacity with a diverse elderly population, provides an important case for studying how health and social care services are organized, financed, and delivered through public-private collaboration. South Korea's elder care system is publicly financed in a nutshell, but mainly primarily delivered by private providers. At the national level, the Ministry of Health and Welfare oversees NHI, National Health Insurance, and Long-Term Care Insurance, LTCI, both social insurance. NHI provides universal medical coverage through private hospital and clinics. LTCI covers care services for older adults with functional limitations, delivered mainly by private providers. At the Seoul Metropolitan Government at SMG level, Seoul plays a key roles in overseeing national programs while also developing its own public health and social care services, particularly for lower-income older adults. Coordinating community-based health initiatives to fill service gaps. Social care services are locally administered and funded through both Seoul as well as central government taxation, with Seoul contracting private social welfare agency to deliver programs such as home visit and meal supports. Long-term care insurance in South Korea provides care service for older adults with functional limitation. Eligibility basically available for all 65 or older and those with geriatric condition, regardless of income level. But not all applicants are eligible. Eligibility is assessed by trained NHI staff using some standardized tool, and they also need some physical statements confirming the applicant has a certain level of functional limitation. For eligibility of customized care service for the adults, this is community-based social care. It's mainly target disadvantaged population. Those are still ineligible for LTC. Their level of needs not that high, but people still need some care needs. They are the target. This also needs nationally standardized assessment too. In South Korea, healthcare for older adults operates through a multi-level governance systems involving both public and private sectors. At the national level, the Ministry of Health and Welfare oversees national health insurance, which finances medical services. Most health services are delivered by primary hospital and clinics under public insurance coverage. At the Seoul Metropolitan Government level, SMG implements national health policies while also operating public health programs to promote preventive care and chronic care disease management. At the district level, public health centers provide localized healthcare services, ensuring accessibility for older adults in the community. This public-private collaboration expands healthcare access, but challenges remain in coordinating service delivery between different actors. Similar to healthcare, social care for older adults also under multi-level governance, they are delivered in the collaboration between public and private sectors. At the national level, the Ministry of Health and Welfare provides policy oversight. And for LTCI, the NHIS basically operate the full financial operation. But for customized care service for elderly, it's partially funded by central government, but partially funded by the Seoul city government. At the Seoul metropolitan government level, Seoul administers public social care programs and contracts private social welfare agencies to deliver services such as home visit, meal support, elderly welfare center for vulnerable seniors. At the district level, local government coordinates service with NGOs and private providers, ensuring customized care service reach those in need. Unlike healthcare, which rely on a structured insurance system, social care is funded through local as well as central taxation and has more regional variation in service availability. The Seoul Health Companion Program for Older Adults, SHC program, launched by SMG, Seoul Metropolitan Government in 2023, supports multi-morbid older adults, especially those living alone or with a spouse, to promote aging in place. Private clinics identify high-risk patients and refer them to public health center for continuity care. Before launching this program, those private and public sectors are pretty much fragmented. They see each other, same patient, sometimes different patients, but they don't talk to each other much. So the program is basically linking the private and public sector collaboration. So private clinic identify patients, but their services sometimes limit on visit for 3 months, per 3 months. But this time now they can refer those patients still in need to monitoring. They refer them to PHC, the public health center. Then public health center's interdisciplinary team can continue follow up their helping their self-care management for their chronic conditions. The blood pressure monitoring, nutrition guidance, physical activity, kind of all the management they can advise and they can encourage them to do their work, basically self-care. So SHC somehow fill care gaps by integrating public health and private medical services, improving long-term support for older adults. This figure shows how private clinic and PHC collaborate to manage your older adults' health. Private clinic refer eligible older adults to PHC, PHC coordinating ongoing care, ensuring patients receive preventive and community-based health services. This public-private linkage helps bridge medical care with long-term community supports, strengthening health outcome for older adults. As we conclude, I would like to summarize the key lesson from Seoul's public-private collaboration model for elderly care and highlight some recent policy efforts. Seoul's elderly care system, in a nutshell, primarily publicly financed but rely on private provider for service delivery. It is closely linked to national-level programs such as NHI, National Health Insurance for health services, and long-term care insurance for social care. While this model expands access, it also presents challenges in cost control and aligning public and private sector goals. Traditionally, Seoul's public health service has limited room for public-private partnership (PPP). However, new initiatives such as SHC program and piloting private sector engagement to enhance care continuity for older adults. While outsourcing for private providers has improved access, it has also led to weak cost control and limited oversight of spending. Ensuring public-private alignment remains a key challenge as private provider operate within more likely market-driven incentives. Lastly, I would like to mention briefly, South Korea has recently introduced several national policy aimed at strengthening integration between health and social care. You see the list, and the act was enacted, so that's the main one. The latter post-COVID era, COVID really accelerated digital transformation, leading to new opportunity in public-private partnership. So more will come. Thank you. That's the end of my presentation.
Thank you, Hongsu. Very informative, a lot to cover in a very short time. Can I take my moderator's prerogative and ask one question at this point, just to clarify one thing? And my team are looking at me and staring at me saying, how dare you? My question to you is that, assuming I'm a 70-year-old lady who's had a stroke and who is being discharged from long-term care with disabilities, which will need home support, I just want to contextualize it. How is that going to work for me as a patient? Is there a caseworker who will link me to the social work with the private clinic, with the follow-up care in the health sector? So how is there how is that work? If you're going back to your previous, the penultimate slide, the triangle slide, I just want to put that in a bit of a context so that the listeners understand in an example, a case study kind of thing.
Okay, I don't have much time, but I will make it.
That's okay, don't worry. Timing is my issue.
So if you are discharged from hospital and you have long-term care needs at home, for healthcare service, you should visit or monitor by your primary care physician or hospital doctor. For long-term care, probably home care nurses and home care worker will visit you, financed by LTCI. But healthcare probably financed by NHIS. If we are poor, no out-of-pocket, it's covered by the social care service by, for example, Seoul will cover your cost. So there is still limitation of the health and social integration. So recently, long-term care insurance have launched an integrated program of medical doctor included in long-term care team. That is the new initiative. Thank you.
Thank you very much. Thank you. That was very helpful. Thank you. Without much ado, we'll move to our second presenter, Alex, who's going to talk about the Hong Kong case. Alex, the floor is yours.
Okay, great. Thank you, Dr. Nima, for setting up such a wonderful webinar. And it has been really a great pleasure and privilege to work with Professor Kim and Professor Baru and other colleagues from India and mainland China. So today, I joined to share the story of Hong Kong. Hopefully, we can generate some sort of takeaway points from the trajectory of continuity of care in the Hong Kong Special Administrative Region. So first of all, Hong Kong. Why Hong Kong? Why is Hong Kong included into this comparative study? Hong Kong, first of all, is a part of China and is a special administrative region enjoying high level of autonomy. And this is one of the Asian tigers and so on. So, and then the other side of Hong Kong is the graying trend of the demography. So one of the super aging societies. If you look at the life expectancy at birth, Hong Kong is probably highest together with Japan and South Korea. And then according to government projection, those aged above 65 years old will go up to almost 1/3, more than 1/3 actually, just in a few years' time. And then with this changing demography, we see rising multi-morbidities. But in the meantime, what set Hong Kong a little bit different from other societies is a tragedy. It's a very high level of elderly poverty rate in such a high income society, because close to half of the elderly population live below the poverty line, largely because of the lack of universal retirement retirement protection, which is pension. And then there's no social insurance whatsoever in this highly liberal and capitalist city. So such a problematic financing regime partially impedes ability to pay for the vast population in the elderly population. And then of course family support system has been weakening. You cannot count on your adult children for providing those care, And then if you look at the healthcare and social care, the division and public-private mix, we also see high level of fragmentation in Hong Kong as you often see elsewhere. So let's look at healthcare first. So we often use the concept of dual track medical economy to describe the nature of Hong Kong's healthcare system. You do see public and private each contributing approximately half to the total expenditures on health. The public system largely resembles the British NHS because Hong Kong was a British colony before, and then the government provides 90% of the public hospital's recurrent expenditures. So the public hospitals largely, are largely financed by the government, and then it provides 90% of the inpatient care services. And then there is actually a sizable private system, but it's subject to very little government regulation. And then the coordination between the public hospital system and the private hospital system tends to be weak as well. And then 70% of outpatient care is provided by the private system. But then luckily, in the recent years, there has been quite big progress in terms of, informational interconnectivity. So the ICT technologies have been quite widely used to connect public and private system. So sharing data, sharing medical records has been possible in Hong Kong. But in the meantime, you do see what we often see in NHS, right? Extremely long waiting time in the public system, particularly in specialist care. That has become a major problem that most Hong Kong people are concerned with in the healthcare system. And the long-term care system in Hong Kong, look, there are some sort of, terminological issues here. Social care in Hong Kong includes actually quite a few types of care, but because most of those care recipients are the elderly suffering from chronic disability, therefore, social care in Hong Kong technically refers to long-term care. So it includes residential care, community care, and support, and transitional care, the care transition between different settings, particularly from hospital setting back to the community, so discharge. So the level of institutionalization in Hong Kong is relatively high. So when the elderly patients, suffer from chronic disability, and then the default option, default choice is to move into the government-funded NGO, which provides professional services, professional residential services at a very, very generously subsidized rate. But again, you see the mirror of the NHS, and then because the long queues have also been a major problem, major hurdle to accessibility. And then in the meantime, you also see, the mirror of the healthcare system in social care, because the private residential care services are widely available, but they're highly expensive and the quality also varies dramatically. In the past few years, we have seen, scandals like abuse, sometimes, sub-quality in the private sector being, exposed, in the mass media reported. So that also drew widespread public concerns on the quality and necessary regulation. And then in order to reduce the waiting time, in order to relieve the burden, the government also, initiated a few other initiatives. For example, they purchase private beds with government finance, and then the eligible elderly can move into the private nursing homes, but still pay the government subsidized rate. This is a very, very typical Hong Kong way of doing things. Hong Kong style PPP, public-private modality, usually operates in such a way, government purchasing services. And Hong Kong is different from South Korea, from Japan, where pretty established long-term care insurance, systems are available. And in Hong Kong, there's no long-term care insurance whatsoever. There are some minor, commercial insurance products, but they are just very, very minor. Therefore, all these factors combined essentially mean that, there's huge unmet demand in the social care, sector in Hong Kong. And then this is a kind of the highlight I want to really draw here today. Needs assessment. Needs assessment is very essential. It's essentially kind of gatekeeping mechanisms, right, in the social care system. And in this aspect, Hong Kong's practice has been pretty laudable. So there has been a standardized need assessment mechanism, which is very, very comprehensive. So the elderly patients and their family members can raise a request, and then there will be initial screening, and then the assessor will conduct assessment and then explain the result. And before you are qualified to move into government-funded, nursing homes, which provide good quality residential services. Because the this project does not only look at public-private mix, we also pay considerable attention to, care integration. How do we integrate various types of care to improve the well-being of the elderly patients? So maybe this slide is of some reference value for the international audience, because there are quite a few, mature, elderly care integration models in Hong Kong. For example, the integrated home care services, they offer enhanced support, care, and rehabilitative services to community elderly. And then you also have this transitional care services, which is called enhanced home and community care services. They create a platform to provide, integrated services for the frail elderlies, particularly those discharged from hospital setting. You have the integrated care and discharge support and the community geriatric assessment teams. So all these, care models share one major mission, that is to reduce unnecessary hospital readmission. So this slide is something very, very new. This is another major flagship program in Hong Kong in the past few years. And so the district health centers, everybody knows the importance of primary care. We should strengthen it. And how do we exactly strengthen primary care? And this is the new practice in Hong Kong. So they set up, so-called district healthcare center in every administrative district in Hong Kong. And then they work to strengthen the gatekeeping and better connecting family doctor, and with specialist care, and so on. Of course, this is still too early to assess the success, the outcome of this model, but for your reference only. So this is the last slide, and let me summarize, the Hong Kong situation. I am a policy scientist. I study public policy. So people like me are more sensitive with governance, with the dimension of governance, because healthcare, in our view, in our disciplinary, lens, is not medicine per se. It's everything is ultimately governance. And we see major fragmentation in healthcare and social care in Hong Kong. And in my view, this is deeply rooted in the fragmentation of governance. As oftentimes you see other countries and other regions, you see, the health bureau, the health ministry is taking care of health, and then, however, long-term care oftentimes belongs to another, ministry's portfolio. So if you have this turf war and you've had this bureaucratic fragmentation, care integration will become very, very difficult. So, South Korea has integrated the Ministry of Health and the Ministry of Social Welfare. Hong Kong has not done so. And therefore, we see that there's pretty strong demand for horizontal integration. Maybe a kind of ministerial restructuring will provide more conducive conditions for better integration between the health sector and the social care sector. And then we also see that overall, from my introduction, I hope you get the view that the public-private mix in Hong Kong is very, very skewed towards the public system, and the public system in both health and social care is overburdened. What the Hong Kong government has done is primarily to make extensive use of supply-side, demand-side interventions, particularly called vouchers. And we also see public-private partnership being widely used. And behind public-private partnership is actually the actual practice is government purchasing private services. And Hong Kong has also made some good progress in ICT tools. So the ICT tools turn out to be pretty useful to connect public and private providers. But of course, we always have to be aware of this great digital divide. How that is going to be overcome needs to be seen. And lastly is manpower. And very, very similar to the situation in Japan, in South Korea, and manpower shortage has also been a major hurdle for Hong Kong's social care system. So I'll stop here and look forward to Q&A. Thank you.
Thank you, Alex. Very informative. I have a whole bunch of questions, but I'm going to bite my tongue because we're running out of time. So you're lucky. I'm not going to ask you additional questions off the cuff. Can I just ask, however, the audience, if you have any questions, please put them in the Q&A or in the chat so that we can, towards the end of the session, we're trying to collate them and bring them to the panelists. With that, I'm going to ask Rama to come in. The first two situations were in the countries where we are actually looking at quite a more elderly population and a more, for want of a better word, regulated approach to managing healthcare and social care across the divide. So I'm going to ask Rama to talk about Kerala and the experiences from there. And then we can have a conversation and a couple of questions. Over to you, Rama. Thank you.
Thank you very much, Dr. Nima, and to my colleagues. As you can see, we began with the advanced location of both Seoul and Hong Kong along the Silver Curve. Then we come to India, which of course is a subcontinent in itself with tremendous variations across states. Next slide, please. So this is just a map to give you a visual impression of the demographic variation and the percentage of older population. We, of course, located our study in Kerala, in the city of Thiruvananthapuram, because Kerala is demographically advanced and it has a very sizable population of older persons. And you can also see the the young old, the middle old, and the old. So you get a fairly good idea of the distribution among the older population as well. Next, please. This is just to give you an idea, because we heard about financing and the very important role public financing has played, especially in the East Asian context. Seoul and Japan, as well as Hong Kong, the public financing has been very strong. They have a near universal health insurance, although it focuses largely on hospital care. But the Indian situation, and especially in the state of Kerala, it's quite dramatic that the role of the central, state, local bodies is relatively smaller, as a result of which the out-of-pocket expenditure is very high. And we have data for older populations which clearly show us that the percentage of older persons, the cost of care, out-of-pocket expenditure goes up. And this is really largely due to the very targeted public health financing that we have for insurance, and absolutely a very minimal expenditure that we have for social care. Next, please. So what we really, I'm going to present now is the findings from our case study, which is that, as you saw in the Seoul case as well as the Hong Kong case, we have multiple actors and agencies in the financing and provisioning of health services. There is a public-private mix in financing of health services. You saw the large out-of-pocket expenditure and a very small percentage of private insurance coverage. And what we are finding is a fragmentation of public financing. This kind of speaks to what Alex spoke about governance. And I think this is very important if you look at the sources of financing. So you have financing from the center, state, and local bodies. And in the private financing, out-of-pocket payments dominate and private insurance is rather small. Now, public provisioning is the primary health centers, secondary and tertiary hospitals. In private provisioning, you have a large private practitioners, you have nursing homes and tertiary hospitals. But these operate in silos. So there is very little speak between private provisioning and public provisioning. The only place where there is some level of mix is through the targeted public health insurance program, which actually empanels private hospitals to provide services with public financing. Next, please. And in social care, we find a very difficult situation. We don't see the kind of maturity that you see in some of these East Asian countries that have been ahead in the silver curve and are innovating to make social care more functional for older persons. Here we really are finding a weak public provisioning and financing, and families continue to be the dominant provider of care for older persons. You have a few community-based initiatives with NGOs, and in Thiruvananthapuram, we have only around 16 public old age institutions, largely targeted toward the destitute poor. But what is also interestingly happening in the Indian context is the growth of for-profit enterprises, catering largely to middle and upper middle classes, and a non-profit institutions, as I said earlier, largely catering to destitutes and poor. They are marginally supported with public subsidies, but these subsidies are very inadequate. And we have several interviews which point to the problems of weak public subsidies. And what we really find is the demand for care services is actually not adequately supported by supply. Next, please. So when we move to the integration within health services and with social care, there are a couple of things I think we need to highlight. One, that given the multiple actors in financing, there is weak integration in the public sector. What we found significantly interesting was that the integration between allopathic and other systems of medicine is practically non-existent. Although with chronic conditions and multiple morbidities, older persons tend to opt for other systems of medicines as a management strategy. We found that this was a major gap, which we found through the case study. And then also the integration within the public sector across preventive, curative, and rehabilitative care is also weak. And it was interesting to hear Hong Su's presentation, where there have been efforts at the local levels to bring in the preventive, curative, and rehabilitative to somehow speak to each other. This we find is actually operating in silos. And the targeted public insurance scheme basically privileged curative hospital-based care. So I think we have a lot to learn from East Asia, that if we create a model which is excessively focused on hospitalization at the cost of preventive and rehabilitative integration, then the health system may actually become inflationary in the long run. And the other issue is the private sector is focused on curative services, poorly regulated, and the integration between public and private sector is very weak. They operate in silos, and there is really no formal linkages between health services and social care in this case. Next, please. Next. Okay. Can we go back to the earlier slide? I'm really sorry. Yeah. So as I said, the challenges that come up for the integration, one is the changing family structure, especially in Kerala, due to out-migration of children. And therefore, you have a lot of, and there is also feminization of aging. So there are studies which are showing us how a lot of older persons are women and they are actually living alone. So this is a major challenge as far as the demographics are concerned. And that there is a lack of social protection for older persons, that there is no universal pension scheme, which is why it also corroborates with the high out-of-pocket expenditure and also a denial of medical care because you're unable to pay for it. And then the split between, and this again, Alex's presentation showed for Hong Kong, the split between ministries of health and social welfare results in fragmentation and really raises a number of challenges for governance. There is a shortage of skilled professionals, especially from Kerala, due to out-migration, and the shortage of skilled workforce in both the health and social care sectors. So you have a lack of regulation and accountability and a lack of public-private partnership guidelines. So some of the challenges that they are facing in East Asia, we see it glaring in the case of the Indian context in general and the Kerala context in specific. And there are financial barriers in access to health services and social care. Inequalities across gender and class become very, very evident. And also there are a whole lot of questions for the quality of care that is being given. Next, please. So there are some innovations, especially in the Kerala situation, where they have had programs at the state-initiated programs to improve access to medicines for chronic conditions for older persons. And this is done through the primary healthcare system. And they're also trying to find ways to strengthen primary level care for older persons. These are innovations. They have to be scaled up. There is co-location of allopathic and Ayurvedic services in certain primary health centers, but this doesn't mean that there is portability of records between the two or a dialogue between the two. There are some experiments at daycare centers for older persons in the community. And I think a very well-known initiative, which is actually a WHO collaborating center, is the Pallium in Kerala. And they have really done very interesting work of engaging with the community and local government for palliative care. And of course, palliative care covering a range of conditions, which also covers older persons. Next, please. So as far as we are concerned, what does policy need to address in this context? And Kerala can become a model for the rest of India as well. It is the first state to have a policy for older persons. Having said all that, I think there are many challenges. One is fragmentation in design and implementation, both within the health services and across health and social care. And how do you build interactions between the public and private sectors for health and social care with equity as a concern at the core? And third is financing and capacity building in a decentralized manner. As we saw, there are some innovations. So what are the learnings from that and how do we upscale it? And the regulation to include accreditation and certification for caregivers and institutions. And I think this becomes particularly important, not just for the private sector, but also for the public sector, and to also have SOPs, standard operating procedures, which could then be used to improve quality. And what we really think is important is an ecosystem of regulation for a specialized range of services. So we have to see from home-based, community-based to specialized care. And again, if you do it in silos, then you don't get from a perspective of the user, this ecosystem perspective becomes very important. And no regulation is possible just by government diktats. I think self-regulation of professionals in both public and private sector becomes very important. We also feel that there is a great euphoria about e-health and digital technology in the Indian context, but I think there are many issues around it, including the hardware issues, the availability of smartphones, but also that there are regulations that are required and there are ethical concerns. And there have been a number of debates about the ethical concerns around infrastructure costs and as regard to e-health. We also feel that capacities for monitoring and evaluation of needs and services required for older persons becomes very, very important. And therefore, I think the learnings from East Asia for the importance of needs assessment is very, very critical for the Indian context. Otherwise, how do you plan for services if you don't know what the depth, the scope, and the extent of needs are for an aging population? Thank you very much.
Thank you, Rama, for that very comprehensive analysis of the situation and the challenges. We are running out of time, so I'm going to cut down some of the questions. There's a question, however, nonetheless, which I think is important, and we have two questions from the audience. Like in a 1 minute thing, this is really a question for Hong Soo and for Alex. You've talked about needs assessment as a fundamental part of the actual equity use and equitable use of the services. I have a question about that. When we say needs assessment, first of all, do we mean financial needs assessment or assessment of the needs of the individual vis-a-vis health and social care requirements? So if you want to just expand a little bit on that issue, Hong Soo first, followed by Alex. Thank you. Over.
The time is limited, so I will be answer quickly. For the means test, we basically have two types of social care I presented today. There are some others, but these are two major, the LTCI, long-term care public insurance. The other one is more likely social care, traditional one is a customized care for all the adults. LTCI is a public universal care, long-term care insurance. So it doesn't have a means test. It's function-based, needs-based. At 2024, we cover about 12%, 12.6% of whole older population are covered, eligible. For the customized care service, is means test based. It's still only for low income elderly. And about 5% of older people are eligible. So that's the current situation. About the question from the audience about AI care call and social robots, they are currently experimented in the context of customized care for older adults, a social care setting. So during weekend and holidays and very hot day and very cold day, usually care worker have to make a call for elderly, whether they are okay. But it's very burdensome for them, as you can imagine. So AI agent, they make a phone call automatically. If an agency, the manager set like a 300 call for their people, elderly, that the AI automatically make a phone call. I think 3 times if they didn't get called, 3 more times. And AI care call is a not very extensive call, but checking if she's or he's okay. If no, elderly didn't get the call, there's an alarm for care workers, so they make a call. Social care robot is similarly for elderly for living alone and lonely. So there's some experiment going on. Some local government agency implement social robot for elderly. So really the initial output from that experience is pretty positive, but as Dr. Baru mentioned, there are several concerns also. So we will see. Thank you.
Thank you. And thank you for answering some of the questions on the chat. Alex.
Yes.
Over to you.
Yes. Thank you. Thank you. The long-term care, the cornerstone of Hong Kong's long-term care system is really the government-funded NGO sector, which provides most of the services. But you will be very surprised in Hong Kong, such a highly capitalist society, the provision of long-term care, government-funded long-term care, is based on universalism. There's no or very little means test. In other words, everybody, even high-income, middle-income elderly with disabilities can move into government-funded nursing homes. But if you look at this is one of the reasons of allocative efficiency issues. But if you look at the technical aspect of it, I must really commend the Hong Kong system, because the needs assessment. If you look at the other countries which have implemented long-term care insurance and so on, so the needs assessment is largely based on daily activities of daily living, right? And in Hong Kong, it's very, very technically sophisticated. They not only look at this, assess elderly based on activities of daily living, but also cognition and communication, their emotion, their behavior, their health conditions, their level of social support and the living environment is truly holistic. I think in this way, Hong Kong can send very, very good example to other countries and regions. But unfortunately, due to the very little means test, I think the allocative efficiency is low, that partially resulting in the long queues. And very quickly to the question about Hong Kong's fragmentation in governance, at the ministerial level, the two ministries, the two bureaus are still working in silo. And then, however, at the operational level, there are quite a few, very established cross collaboration mechanisms, particularly post-discharge plan. And all those efforts which connect social care and hospital care to prevent unnecessary, hospital readmission. I think these are programs which have been running pretty successfully. But my point is governance is overarching. Government is more important. Governance is strategic. If the ministries are not consolidated or there's a little ministerial coordination, then you cannot guarantee that the formulation of larger policies is coherent. So this is one of the key arguments we put forth in the report. Thank you.
Thank you, Alex. Thank you. And just following from that conversation on integration, I want to bring in Rama. Rama, I know we said originally 5 minutes, but can we bring it down to 2 minutes just for interest of time? What do you think are the agents involved in the integration of services for the older persons from public and private, and how do they interact? So we're going back towards the model that we've talked about. Over to you, Rama.
Yeah, thank you very much. May I request the slide to be beamed, because one of the things we really struggled with as a group is that what is the framework that one can use for actually trying to understand the need for continuity of care. And I think we all agreed that we kind of used this, we came up with this diagram in the Delhi workshop. So we call it the Delhi Framework for Public-Private Mix for Continuity of Care for Older Persons. So what we are saying is that you need health services and social care, and these are not two separate. It's not just about integration of these two. They are essential for continuity of care. So this becomes a very important way in which we frame it. Then we also are looking at the various sides of this triangle, where we are saying who are the major actors. And in all four case studies that we did initially, we had the public, we had the private non-profit, and private for-profit, and we saw the need to make that distinction. And then we had the third, which was the informal sector, which includes the family. Irrespective of how evolved your services were in these two other East Asian contexts, the family still continues to play a very important role, as does the community. So what we are really looking at is three very important interrelated aspects, which is that there is co-production. There needs to be co-production. If we are thinking of a system which will be all publicly funded and all publicly provided, that's not going to happen. So we have to take this idea of co-production very seriously. And in order to do and to effect co-production, you both need regulation for accountability, accountability leading to regulation, and then speaking to this idea of co-production. So I think we came up with this framework to say that you can apply this to other contexts. You can see what are the gaps, but you can also see what are the pathways for better integration to provide continuity of care. So the goal is for continuity of care, but the process through which we would do that is through co-production and the interaction and between the public, the non-profit and for-profit, defining roles, defining governance structures in order to do that.
Thank you, Rama. A very comprehensive approach to trying to identify, to solve the challenge. And moving from that, I know that, and thank you, Hong-Soo, for answering the questions on chat as they're coming up. Some of these questions are very specific, so I'll let individuals to answer those as and when necessary. But I want to bring this thing together. We have 2-3 minutes, and asking everybody, just from your point of view, what policy implications or recommendations or prescriptive takeaways do you think you have based on the study, which can be applicable to different countries and different settings? Let's start with Hong-Soo, and then we go the same way, if that's okay.
Okay. I think basically
over to you.
Okay, one size doesn't fit all. We have our challenges and strengths. So we can learn each other, but we can also figure out what's the best for our situation. So collaboration and international learning is always very helpful. Thank you.
Thank you. Alex.
I think the learnings Hong Kong might offer to other regions is, number one, the ICTs. These are very powerful instruments that can connect, caregivers and care providers across different settings. Without such infrastructure, any operational level integration will be hard. So this is number one. And number two is the needs assessment. As I said just now, I think Hong Kong has done a pretty good job in setting up a comprehensive and sophisticated needs assessment framework that can be very useful for other countries and regions as well. Thank you.
Thank you. Rama, I'm going to ask you a different one, just because I can. We started this journey because the Kerala government came to you and asked, we want to understand what other countries are doing. So what is your advice to the local government from this? So same question, but just in a context. What would you tell them?
Yeah, I think a couple of things. There is an appetite in the Kerala government, and they realize the need for integration and co-production. But I think the cornerstone, which I took away from the East Asian experiences, you need a needs assessment. A needs assessment And I know there are ICOP tools, etc., which we've been studying carefully. But I think the point that Alex made about a needs assessment, which would be comprehensive, which would not just be looking at one aspect of living of elderly. And he spoke about cognition, he spoke about the familial structure, he's also spoke about built environments. And I think we really need to sort of make that the cornerstone of even evolving a policy which would address those needs. I also think the financing structure is a huge challenge in the Indian context. When you have a universal health insurance scheme like and you also have a long-term care insurance, so you are able to actually control to some extent. Although Hong Soo, you made a very important point that the private sector is quite hard to harness. But having said that, you at least have the instruments of state policy to be able to, in some way, regulate maybe quality, regulate costs, regulate maybe even other infrastructure, although the behavioral aspect is not something that gets easily regulated. So I think that these are the two important takeaways. And the third, which makes Kerala particularly conducive, is that there has been a history of local self-government, which is a political history of Kerala, and that has provided spaces, especially in rural areas. Their panchayats have done much more work in engaging with innovations and also creating spaces, integrating with their existing programs. There was a question on self-care I think self-care has now become a very important aspect of policy. But having said that, self-care without the adequate institutional support and structures at primary and secondary levels can actually just mean family then takes care. So, there is a bit of a danger in this self-care. Self-care without support, and a lot of older persons' conditions require technical and specialized support. So I hope that self-care idea won't just get reduced to take care of yourself. So that's where I would like to, I think I'll end here, Nima.
Thank you very much. Thank you. Thank you. Thank you to all of our speakers. I want to thank the audience. We're coming towards the end, really. We're just a couple of minutes over the thing, and Zoom is probably going to cut us any minute now. So again, I want to thank everybody for attending, for finding the time to share your thoughts with the audience and with us. This will be available on our YouTube channel and will be available on probably on our website, but certainly on our YouTube channel. I look forward to talking to or to seeing the audience when we talk in our next webinar, which is going to be focusing probably around Thailand and the cost effectiveness of the healthcare services in Thailand as the next one. And with that, I want to thank everybody and wish you all a good morning, evening, afternoon. Thank you.
Thank you.
Thank you.
Thank you, Nima.
Thank you, everyone.
Thank you, everyone. Thank you.